Greetings, Dr. Dave here with another Journal Club on behalf of Healthy But Whole. This study that we're going to talk about today is Ticagrelor or Prasugrel in patients with an acute coronary syndrome. This article is abbreviated the ISAR React 5 trial that I've put here in the study citation. It was published in 2019. The purpose of this study was to assess the management of acute coronary syndromes, which I abbreviate ACS, for the use of dual antiplatelet therapies, in particular the P2Y12 inhibitors. So I make this statement here at the start of my background that in ACS, dual antiplatelet therapy using a P2Y12 inhibitor and aspirin is an absolute, because it truly is. When somebody comes in with these acute coronary syndromes, in 9 out of 10 cases, it's somebody that's going to end up on DAPT. And the reason DAPT is used is that it's able to prevent a thrombus within the cardiovascular system and or within the surgically placed percutaneous coronary intervention, which is abbreviated PCI. So this means that the thrombus, which is the blood clot in the vasculature, is either, just with if they do a POBA, so a plain old balloon angioplasty to get rid of that thrombus, or if they actually place a stent, which I abbreviate PCI, which stands for percutaneous coronary intervention, the dual antiplatelet therapy prevents rethrombus, right? And so because of this concept in using ADAPT in the management of ACS, it's going to be a class 1 recommendation based on extensive evidence of beneficial effects. It makes sense that if we're trying to open up somebody's vasculature to prevent this ischemia, that using thrombotics are going to be very useful to prevent that thrombus. However, the reason that this study was published, and at the time of publication, there was a lack of evidence for which P2Y12 inhibitor. And so all we really knew was, these newer generations of Ticagrelor and Prasugrel were probably better than Clopidogrel, but we didn't really know which was more effective between the two. So the only clinical trial which compared these two medications was terminated early for futile results. So these both have been established as superior to clopidogrel. They just have no data that said which is better compared to the other at the time of publication. The futile results of this prior trial that I alluded to, I have the citation down here. It's the PROG study. So the PROG study just basically found that it wasn't worth looking into. There is no difference. So again, the study objective is to determine the superiority between the P2Y12 inhibitors Ticagrelor versus Prasugrel for patients presenting with an acute coronary syndrome, with a plan for percutaneous coronary intervention. So this study is an investigator-initiated European multi-center phase 4 randomized open label clinical trial. I emphasized a couple of words on purpose there, and we'll talk about them in the discussion. The primary funding was through the German Center for Cardiovascular Research, and all data analyses were performed by trial statisticians, verified by the authors. That's verbatim how it's written in there. Inclusion criteria is those who were hospitalized for an acute coronary syndrome, so STEMI, NSTEMI, or unstable angina, needing coronary angiography, and those older than 18. Exclusion criteria was stroke or TIA, or intracranial disorder, being a hemorrhage, neoplasm, venous malformation, aneurysm, bradycardia risk, which they summarize as being those with a sick sinus, an AV grade block 2 or 3, or history of syncope, or life expectancy less than 1 year. They also excluded those who were actively bleeding or at a bleeding risk based on clinical findings, those who had had fibrinolytic therapy within 24 hours of randomization, those with a platelet count less than 100, and hemoglobin less than 10, and an INR greater than 1.5. Individuals with chronic kidney disease on dialysis or cirrhosis with a Child-Pugh classification greater than B were also excluded, and the treatment with an experimental drug within 5 days of randomization, concurrent CYP3A4 inhibitor, or oral anticoagulants, those were all excluded as well. So for patients enrolled and thereafter randomized to receive treatment, Ticagrelor was immediately started following randomization at a dose of 180 milligrams followed by 90 milligrams to be continued. Prasugrel was started based on presentation at a dose of 60 milligrams to be continued at 10 milligrams daily. Follow-up was then scheduled for 30 days plus or minus 10, 6 months plus or minus 1 month, and 12 months plus or minus 1 month. The primary outcome was a composite of death, heart attack, or stroke at 1 year. So all of those different criteria into one composite. The secondary outcomes were the incidence of bleeding and stent thrombosis, and then each individual incidence of these subgroups of the primary outcome. I included some information about the statistical analyses that were done. So it was conducted on an intention to treat principle, which means all that were enrolled in the trial were included in a final calculation of all data. They did adequate sample size calculations. They did appropriate statistics for categorical variables versus continuous data, bunch of stuff that I'm not going to blabber about because I don't think there's any statisticians watching. So looking at the results, the sample size that they obtained was 4,018, 2,012 of which got to Ticagrelor group, and the rest were assigned to Prasugrel. Baseline characteristics, we see an age of 64.6 plus or minus 12, females being 23.8%, an average blood pressure of 144 over 82, heart rate 77, BMI 27.8, presenting with unstable angina is the most frequent, STEMI being the second least infrequent, and in-STEMI being the most frequent. Interventions in the form of PCI accounted for 84% of the patients, cabbage 2.1, and conservative therapy was chosen for 13.8% of patients. So, looking at the results, so I first included the results of the randomization because it's something they talked about a lot, and I think it's something worth us really looking at when you look at this trial. So, loading doses were administered within 6 minutes of randomization for the Ticagrelor group and 61 minutes for the Prasugrel group. This doesn't reflect any massive disparity between the groups, it's just how clinical practice utilizes these different treatments for these patients. Ticagrelor used immediately, whereas Prasugrel you'll use a little bit delayed, but that's a different video for a different time. Treatments were continued at discharge for 81% of the Ticagrelor patients and 80.7% of the patients on Prasugrel. So that one definitely raises a lot more eyebrows because this is saying that only 80% of the patients within the trial were discharged on the medication. At 1 year, treatments were continued for 15% of the patients taking Ticagrelor and 12.5% of the patients receiving Prasugrel. Again, kind of a surprise that it whittles down so far. You know, usually the duration of these P2Y12 inhibitors after acute coronary syndromes is a year. So seeing that massive decline is pretty significant. So for the primary endpoint, which is that composite of death and heart attack and stroke, Ticagrelor versus Prasugrel showed a hazard ratio of 1.36, which means the latter had better outcomes for the primary endpoint, and they say these are statistically significant. And the secondary endpoints, the death from all causes, it was 1.25. However, the confidence interval crosses 1, so it cannot be statistically significant. Heart attack incidence, less common in Prasugrel. Stroke, again, less common in Prasugrel, but does cross 1 on the confidence interval. And re-stent thrombosis, again, favored Prasugrel, but was crossing 1 on the confidence interval. On the left, I've included the Kaplan-Meier curve towards these primary endpoints. Safety endpoints showed that there was no difference really in the bleeding for Ticagrelor versus Prasugrel. BARC score of 5 is you died because of the bleed. 4 requires a chest tube or blood transfusion. 3 is intracranial bleed, something that requires surgery or pressors or requires a blood transfusion. 2 is just any treatment less than that. So BARC scores greater than 3 are really your significant bleeds. 2 are just your general bleeds, but overall doesn't matter because there was no difference there. So towards the primary endpoint, Prasugrel was seen to be superior. With the secondary endpoints, the only statistically significant finding is that there is a decreased risk of heart attack for Prasugrel. No significant findings for the safety endpoints. We always like to include at least one grammatical error have been found. So strengths. This is an investigator-initiated trial. So that was something I emphasized when we talked about it. So this means that it's not something that's initiated by somebody trying to get the drug to market. This was initiated by practitioners who had felt as though there wasn't enough information to make claims in a clinical practice the way they wanted to. So definitely motivated from a right cause. There was broad inclusion criteria. They said, let's look at everybody that comes in with a heart attack. They did have broad exclusion. We'll talk about that later. Promising subgroup analyses. Nonetheless, limitations. So I said broad inclusion criteria is a strength, but I also think the broad inclusion criteria with a strict exclusion kind of could cherry pick your population, right? If you're saying everybody is okay to be a part of this trial except for you may actually get a picture of a healthier trial population. Solely European, this is America. America's the best. How dare you? Open label trial design. So when I talked about this in my cardiology rounds, I was told that, open label is not necessarily a limitation. I disagree. And that's why I put the all investigators assume Ticagrelor be superior, a statement from the primary author, here as a limitation. If everybody goes in under the assumption that one will be superior and then everybody thereafter knows what the individuals are getting, it is very prone to bias. But when you look down at the data, I do think it impacted it. Because if you look at the amount of patients that were discontinued from treatment, I highlighted dyspnea here. So patients with Ticagrelor, 44 were discontinued for the incidence of dyspnea, whereas only 1 in Prasugrel was discontinued for dyspnea. And we know as clinicians that Ticagrelor is a high incidence of dyspnea. Prasugrel does not. And this just really highlights the influence that knowing those factors could have on the disposition. Being that if I start you on a drug that I know is prone to cause shortness of breath, I will be much more likely to stop that drug quickly compared to not being sure which side it is on and, letting the drug take a course of action. Whereas a practitioner may have quickly seen like, ooh, it's causing a little bit of shortness of breath. Let's get them off that therapy. Because again, if it was a closed label, I don't think that the discontinuation rates for dyspnea would have been as significant. Nonetheless, it is much more difficult to conduct a trial that way. There's also somewhat triptych data. So when I talked about nearly 20% of enrollees not being discharged on the treatment, it's a little bit hard to understand. And then the safety endpoint analyses where they don't have, any significant findings between them. I don't know how they didn't find statistical significance between these dropout rates. So a little bit hard to understand in those sense. In clinical practice, I think the fact that a lot of people are going to have a change based on the actual coronary intervention that is undergone while they're having a stent placed, right? You thought you were going to need them on DAPT going home. All of a sudden, something changes, right? It's very common in practice, but it does just, create a barrier to really using this data to any significance. So the author's conclusion was that for patients with ACS and the incidence of death, heart attack, or stroke was significantly lower among patients who received Prasugrel compared to Ticagrelor without increased bleeding incidence. Personally, I think it's promising that Prasugrel still holds validity in being used within our treatment algorithms, but I support the fact that the guidelines were not persuaded by this study to say Prasugrel is superior to Ticagrelor. I think all of the holes that we found here within the article and gaps of, does that really make sense to exclude and include? And what data were we collecting? Was it long enough? Did the interventions make sense? Is the blinding realistic? Did really limit this from impacting clinical practice immediately. I think it was hypothesis generating, and in doing so, it's good science. But that is all. I will stop blabbering. This has been Dr. Dave with Healthy But Whole, and have a good one.